Hello, everybody, and welcome back into this week's 30 Minutes program. We're going to be talking about pharmaceutical business, and this is Jason Kizer sitting in the seat today with me, and I'm really excited about learning more about what it takes to get somebody well, some of the problems that people have in taking medicine, but more importantly, the cost of medicine. And Jason, at Kizer Pharmacy, Union City, your family and you have been in business for a long time helping people, and I want to say thank you for doing that. But more importantly, you've had your thumb pretty much on everything that goes in, deals with legislature and what happens and things that kind of surprise us. So I've got to ask you to begin. When did you decide you wanted to be a pharmacist?
I was in high school. And the guidance counselor had a book, and it showed the highest starting salaries. And at the time, which is not near what they make today, was impressive to me. But also, I knew I wanted to own the business because my parents had been in car business and other things. I knew I wanted to be a business owner, but I liked medicine. I was just a sickly kid. I was sick all my life. And so
what were your sickness?
Well, I had asthma. I had weird things like spinal meningitis.
Oh my.
I was an accident unattended kid, I think, because I had 23 broken bones. So I was always taking medicine of some kind, and I was just interested in it. So after that, I went to college and just majored in pre-pharmacy, and the rest is history. I just went to pharmacy school I played baseball for a couple of years at Lambeth, which is in Jackson. And then I went to pharmacy school at Sanford in Birmingham and moved to Nashville, worked for the chain world for a while and became a district manager and worked in their corporate office, saw how they do things. And then I went to work for a very innovative pharmacy in Murfreesboro, Reeve Sane. And one of the owners, they've sold that since and restarted it in other ways. But one of the owners was Shane Reeves, who's a state senator now. But I learned a lot from them. And then I wanted to open a pharmacy in a small town, even though at the time they said it's hard to run an independent pharmacy. But I thought a small town, it would work. Whereas a big town everywhere is service, convenience overrides service in a big town because people just want to get home. There's a long commute, things like that. But in a smaller town, everywhere is convenience. So service could override convenience. And that was my concept going in. And I thought if I just staff my store well, be innovative, be on top of my game as a pharmacist and love people and go the extra mile, I thought there would be a portion of Obion County that would appreciate that. And that's where we started.
There's been a lot of changes in pharmaceutical business, and I don't want to go too deep into this, but since you grew up, what are some of the drugs that have come out and those that have gone away?
In the 80s and 90s, probably, we had penicillin and things like that in the 70s, and we had a lot more compounds many, many years ago. In fact, compounding goes all the way back to Exodus, but then it became a drug company-focused product starting really in the 70s and 80s, and in that time, the stomach acid blockers like Tagamet, those were inhalers. And then the 90s came Prozac, cholesterol medicines like statins, Lipitor. Those were big blockbuster drugs. And then some of the patent laws kind of changed. In a way, there was drugs that were called biologics, which are specialty drugs. And those at the time had a longer patent life. So the drug industry put a lot of their focus in these very, very expensive specialty drugs. Most of the TV commercials you see now are specialty drugs. They end with a MEB or a MIB. If you look in the little parentheses of the names, those are super expensive medicines, and they have a long patent life. Now, I can't remember exactly, but about 10 years ago, Congress or the government ruled that biologics can go generic or be multi-source. They call them biosimilars. But so that for a while contributed to the explosion in drug cost because in the 90s there were very few specialty drugs. And honestly, sometimes, quote, a specialty drug is just because the insurance company called it a specialty drug. It's not. There's not really anything special about it in a lot of cases.
I got to tell you, when I watch television, I see so many pharmaceutical products. Now, why? I mean, it seems like about every 6 weeks we're seeing a new product.
Oh, yeah.
The one that kind of caught my attention happened to be with weight loss.
Oh, sure.
Now, you can talk about it or by name if you wish.
Sure. Well, there's only 2 countries in the world that allow television advertisements of pharmaceuticals, us and New Zealand. So there's been moves to try to curb that. Sometimes people say that that's just a way for drug companies to pay for positive media coverage. And that's a little bit conspiracy theorist. But the other thing is, most of the time, you're dealing with rare diseases like cancer or Crohn's disease and things like that, where I don't think I would feel comfortable just walking into a specialist office and saying, hey, I saw a commercial last week. I think we ought to try this and change course. But the stats show that does work, and it does cause those drugs to sell more.
I mean, we have things that deal with intercourse. You have things about got too much around.
Weight loss.
Yeah. And I mean, there's a whole bunch of those. Are they good stuff, that gets advertised like that? Or is that?
They're very powerful, and they're not without side effects. But for those that are in extreme conditions, like let's say someone's very obese and they're headed towards heart disease and chronic disease, those drugs can provide a kickstart, I think. I'm not sure they're meant to be lifelong, but ultimately they talk about biohackers in the wellness space, but ultimately these drugs hack part of our immune system or the inflammation cascade, or in the case of the weight loss pills, are hormones that govern our appetite and kind of untricks our appetites that have been tricked by perhaps the highly palatable but nutrient void foods. And so we tend to be constant snackers sometimes. Those are ultimately affecting inflammation. In fact, most all of those very expensive drugs you see for plaque psoriasis and these strange inflammatory diseases, almost all of them are trying to blunt an overactive immune system that is causing excessive inflammation.
I'll give you a thought here. Cholesterol, and everybody seems to have the number is too high, and the doctor suggests and says, all right, here's a script, and go down to whichever one it happens to be. And they're really excited because now they're losing weight. Their appetite is not as good, or maybe not at all. And then the next thing you know, things kind of get a little bit vomiting, and some other things. So, I mean, but those are the kinds of things that, you're seeing on TV. And even with the new medicines that are out there, I mean, if you were going to have a new medicine that's just out, would you want to see it right away, or would you want to wait about 2 or 3 years and see how things are?
That's a good point you make. A couple of things. One, pharmacists get 4 full years almost of pharmacology. We're talking about drugs and what they do to the body for 4 years once we get into pharmacy school. And I'll be honest, I went to school in the early 90s, and we learned all about microbiology and the cells and the liver and diseases. But then ultimately, our solution was always, what prescription do we give you? Because we can make things happen with the body with those prescriptions. And I felt like we left out a lot of the other parts that are now we're seeing that are important. Nutrition, wellness, supporting the body to help it run as well as it can. And doctors kind of were trained the same way, with a lot less pharmacology, but a lot more diagnosing ability. And I think that part of the market is starting to turn around. But when I had a UAB professor at UAB Medical School that taught some of our pharmacology at Sanford, and his statement was, never prescribe a new drug to a friend for 1 to 2 years and a family member for 3 to 5 years. Now, that was in the 90s, so things have changed. We've got data a little bit better on some of these things, but you make a good point. But I also believe prescription drugs are a tool to be used, but not the only solution.
Yeah. If you've just tuned in today, we're talking with Jason Kizer. He is a doctor of pharmacology and also a pharmacist in his own business at Union City. Many of you have seen Mr. Kizer at the corner of a very, very busy corner in Real Foot Avenue in Union City. Let me jump over here for just a couple of moments. And this is probably the biggest thing that people are so upset about, and it's the cost of medicine. Why is medicine so expensive. And does the government help us much for particularly seniors, maybe those who are on a situation in their family where they don't have any money, but yet they need to get that pill or whatever it happens to be? So where are we with that?
This drug supply chain is what I would call it, is a very complex, sometimes by design model that if I had long enough to discuss it and could simplify it well enough, you would be certain that the system is broken. And I think most people, when they go to the pharmacy counter or they get their insurance premiums increased and the unaffordability of a lot of this, they learn that that there is a problem, but it's understanding where's the money going and who's making the money. Who is
making the money?
Well, I'll tell you that the people doing the services, dispensing the drugs, and providing the care, and I include doctors and nurses and pharmacists, hospitals in that, they are making the least. In fact, there are many drugs today that almost the more expensive it is, the more money I lose. Okay,
let me stop with you for just a second. You got a script that's been called in, and it happens to be for, we'll use the one a moment ago, obesity.
Yeah.
So the doctor has said, this is what we want you. What are there, 2 or 3 of those items? What are they?
Ozempic and Mounjaro are it's the same drug, but those are for type 2 diabetics. And then you have the other name of those is Wegovy and Zepbound. And they've recently brought out Wegovy tablets. And as of today, they approved Mounjaro's is a pill called Foundia. I don't exactly know how to say it. It's so new.
Well, by the way, I should ask you this earlier. Why do they have such hard? I've seen a lot of medicine, and it's hard to even. I didn't know what tamsulosin was until So I don't know how to pronounce that, but y'all know what it is,
right? So. Well, it's kind of like reading the Old Testament. You just have to say it with confidence when you can't pronounce it. But it's partly a chemistry. There's chemical names that you see on the side of a Coke can, for example, and they are what they are. But the branded names that they come out while they have a patent on them, like Wegovy or Ozempic, those I guess they hire a consulting firm to say what rolls off the tongue best, and used to they would say what is easiest to write. What handwriting of a doctor, what would be easier for them to write?
Okay, so back to my question about, let's say, Ozempic. Now, that thing cost what?
$1,000, roughly.
If you don't mind, how much do you make on it?
On almost every Ozempic medicine that cost us $1,011, I think, somewhere in that ballpark is my cost to acquire it. We actually get paid up to almost $100 below our cost in some instances. We get paid, I'd say on average, $40 to $70 below our cost, which is one of the reasons the negotiating ability of pharmacies with insurance companies that own the pharmacy benefits part of that now. There is no negotiations. It's take it or leave it contracts. And that's one of the things that is, in addition to some other bad practices and conflicts of interest, that is what's caused a third of community pharmacies, chain and independent, to close since 2012. Okay,
here's what I just heard you say in my words of listening. Things aren't right.
They are not right.
The patient needs
the medicine.
And it costs too much, and they can't afford it. And who's isn't the government going to help me to get well? What happens next?
There have been some, by providing some sunshine on what's going on behind the curtain in some of these deals, the government has made some moves to make this better. The mechanics of it are a little difficult, but I do feel a little better going forward that we're exposing. The Federal Trade Commission has fought very hard to expose some of the things that should not have been going on. And if you go back to that Ozempic example, $1,000 drug, we get paid less than that. The wholesaler that I buy it from makes a little bit. The pharmacy benefits manager, which is the middleman that sets the price, what the copays are, all that stuff. It's on your insurance card if you look close enough. they get about 70% of that. They get up to $700 in what they call a rebate. They have an anti-kickback exemption. So they can acquire a rebate from the manufacturer. And the reason they can, they say, we won't cover your drug at all if you don't pay us that ransom, so to speak. The manufacturer has got about $300 in it.
Let me see if I can take this down the road. Kind of makes you look bad.
Yeah.
I mean, and you have nothing to say about it because it's not on you. It's the government. Is that who it is? Or is it Big Pharma? I mean, where's the problem that it started at?
Yeah. If you go back to the early 90s when pharmacy benefit managers, which are the claims processors, they control the drug market as far as who pays what. They got an anti-kickback exemption. That's laws that were put in place to rein in the mafia from bribes and things like that. But they got an anti-kickback exemption to allow for this, what we call the rebate game. And in order for your drug to be covered on our insurance plan, you have to pay the fiddler to get access, basically like a storefront. If Lowe's Stanley Power Tools pulls up and they're going to want to put their products on Lowe's shelves, there's somebody standing at the door saying, hey, before you can bring that and put it on our shelves, you have to pay me. And that's kind of the middleman that's the gatekeeper. But the gatekeeper, in this case, also owns their own pharmacies, and they are able to control every claim that goes over these processing claims wires. Another conflict of interest type thing is they started doing what we call spread pricing. I know that's a bizarre term, but basically pharmacies get paid one price. The employer and patient get charged a completely separate price, and no one is allowed to disclose what each got paid. So if I got paid $10 at the pharmacy and the employer got a bill for $80, he just thought the price was $80. And for a speed of light transaction, the manager of that benefit is able to put the difference in their pocket. So that's some things that we've discovered over the years, and actually in certain states, including Tennessee, have moved to outlaw these practices.
All right, I want to ask you to summer on this word here, but let me come back to this. If you've just joined us, we're talking with Jason Kizer. He owns and operates Kizer Pharmacy in Union City, and he's in touch with legislative events and things that deal with going to the doctor and finding out what pill, and then at the same time finding out what it's going to cost and all of these things. Is the federal government helping people that need help? Are we helping enough of our people?
They have hurt and helped. There have been unintended consequences from their things they have put in place in the past. For example, Affordable Care Act had some unintended consequences that incentivized insurers to optimize the profits they can get from their pharmacy benefits because it doesn't account towards the ratios that they're required to have. But it also took away the lifetime maxes of prescription drugs. And so now you have $4 million lifetime maxes of benefits. We used to be like $1.5 million on average. So after you met that, you'd exceeded your lifetime benefits of insurance. Well, now they have prescription drugs now that are as high as $4 million a year.
Sir, say that again, please.
Yeah, there are infusions for rare diseases that approach $4 million in a year.
Who's paying that bill?
Well, sometimes that's paid for through the medical benefits, sometimes through the pharmacy benefits, but ultimately there is a reinsurer that the employer's out several $1,000s, and then their other insurance policies kick in.
What's the biggest problem that you're dealing with today? I mean, do you have the ear of the congressman of the United States, 8th District, David Kustoff, and the two senators, and State Representative Rusty Grills and Tandy Darby and Chris Hurt and all of these people? You have to talk to these people, I guess, at some time. And what are you telling them?
Well, there's extreme pressures.
And I think you speak for all, not all pharmacists, but I think a lot.
A lot of pharmacists. I feel comfortable speaking up for some chain pharmacists as well, because all pharmacies, if you don't own an insurance company and you can't steer people to your pharmacy and set prices, all pharmacies, chain and independent, are under enormous pressure. In Tennessee, 64 closed last year alone. 300 have closed in the last few years in Tennessee, and 800 since, I think, 2017. There's no pharmacy in Troy, Tennessee anymore. in the years past, if that were to sell or close, somebody would have gone in and opened a pharmacy. They're not anymore.
Hickman, Kentucky.
Kentucky's closed. There are pharmacy deserts now in Tennessee. There are places where people have to go 35 miles to a pharmacy or through the mountains or whatever. And so that is difficult. Now, if I'm a pharmacy benefits company and I have my own mail order pharmacy, I don't care if your pharmacy closes, I'll mail it to you. And so and the other part is in the chain world, they're under such profit pressure. One, Rite Aid went bankrupt. So did Fred's. Walgreens has closed 700 stores. There's a brand new one down in Brownsville that's sitting empty. And the stores that are remaining open are severely understaffed. And that is both dangerous and not great for patient care. When you have to wait many hours for an antibiotic or you can't speak to the pharmacist like you would like to, health outcomes are worsened.
What's the message you are trying to share with you and your colleagues that will help the patient?
I think the message is more transparency, more government help, which there has been some help recently for the patient, not so much for the pharmacies, but more transparency on what's going on and also acknowledging the fair marketplace. You know, AT&T was broken up. There was a company called Merck Medco that the FTC broke up where a drug company owned a pharmacy benefits company and they broke them up.
Do we have some of those here?
We now have vertically, what they call a new name for monopoly is vertical integration. And the Federal Trade Commission is now walking back or wishing they hadn't have done some of these, allowing these mergers. They've actually investigated these companies, and there are three very huge companies that are in the Fortune 10. They do health insurance, but they also own hospitals and doctors' offices and mail order pharmacies, and one company owns brick and mortar pharmacies. And so when you can set your own prices and your competition's prices, and you can steer people to your pharmacy, and then as you're putting your competition out of business, you can offer to buy them for pennies on the dollar and consolidate the market even further. And so in the face of growing prescription demand, an exploding chronic disease crisis, and access to care, especially in rural areas or underserved urban areas, you're seeing less access and less quality service, all under the guise of savings. But what's really going on, if you look at the hundreds of billions of dollars in profit these companies are making at the expense of everyone else, employers are duped into thinking these are good deals. And they're starting to discover, like Tyson Foods has, that they had a relationship with the largest PBM and insurer for years. And they became the first Fortune 500 company to fire one of the big three PBMs.
What PBM stands for?
Pharmacy Benefits Managers. They're like the MasterCard and Visa of all the prescription claims that a pharmacist transmits through their computer. It comes back and says, Paul Tinkle owes $10 for his such and such. And the employer is responsible for paying the remainder of that prescription, for example.
You have a message for your customers, the people listening to our product here today, and then you have a lot of local friends here in the pharmaceutical business and good people. Mm-hmm. I mean, you have relationships with people. What's the message today about drugs?
Well, if I'm talking to just the average patient, one, there's a preparation and thinking ahead in wellness and taking care of your body as good as possible. Prescription drugs are a necessary tool. I always think, is there a generic option for me first? Mm. That's the first thing I always say. Now, there are some brand name medications that are very powerful and do a great job, but also you need to go somewhere where you know your pharmacist, and it's not just a vending machine. I think it makes a dramatic difference really in your pocketbook, because there's oftentimes we go, hey, we've got a coupon card for that, or you can cut that pill in half. Or you actually, let me call your doctor. I'm not sure you're supposed to be on that medicine. And those are things that help you stay out of the nursing home, out of the emergency room, and living a long, healthy life. It's a multi-pronged approach. I think healthcare is becoming more of a team than it used to be. Doctors and pharmacists and nurses seem to be more collaborative than they used to be. And then I think the patients are becoming more wise to what the problems are in the financial part of the healthcare space. But also they're getting more information on how do I get healthy and stay healthy, because getting sick costs too much.
You know, I was just thinking about Suzanne's Pharmacy, Bob's Discount Pharmacy, Evans over in Fulton, and there's several others. I did not mean to leave anybody out. But,
right.
And Kizer Pharmacy, of course. There's a relationship amongst this group. Am I right? I mean, maybe closer.
We try to be. When I first opened in 2003, there was not a lot of. We were more competitors at that time, and it was about how many prescriptions could you fill, and that was it. And now younger pharmacists came on board, and I've got several friends that are all around me, but we talk every day, and we help each other and try to offer help when we can. So it's been, I don't think pharmacies would have survived as well as they have had you not had that collaboration.
I would be remiss if I didn't ask you, what is the best piece of advice when a customer comes in with a script, a prescription? What is it that whether it be that first time or first time with a new medicine, what do you tell these people?
Well, one, it's law if it's a new prescription that they get counseled. So if they're going to a pharmacy and they're not getting counseled, I know that can sometimes delay your time to get back in the car and get home, but it's very important. A lot of times you can actually catch an error at that spot that you didn't know because the patient says, no, I'm supposed to be taking something else. So you catch errors there, but you also get some clinical pearls that, for example, small things like you have to take this on an empty stomach, or this is going to make your magnesium levels drop. You probably should supplement some magnesium or CoQ10. Take it earlier in the day. These are things to help you sleep. Or this drug could be addictive. There's might be a better option for you. And it all comes from a personal relationship that you hopefully we can't always meet that to everyone's satisfaction, but that is our goal. And it's almost like being in the hospital without an advocate with you. It's always great to be in the hospital and have a nurse that's your sister that's in the room with you. We're trying to be your healthcare advocate that's not necessarily your family member.
What is the advice that you need to give to the patient?
They need to learn more about their condition. They need to learn more about their disease. You'd be surprised how many people call and say, I need my white pill filled. And that doesn't cut it. And when you go to the emergency room.
But it's important, though.
Right. You need to know the names. You need to know what they do, what they interact with.
One of the things that people in Weakley County Prevention Coalition and Obion County and so forth, they have a take back day. Get those old pills that need to get off of the street or out of the. But the bottom line is making sure that if you don't take all your medicine, then you either need to throw it away or do something. I don't know what to do. What's the answer to that? Well,
there's drug takebacks at our police station, for example, especially if it's a controlled substance or a drug of abuse. That's very important to get that out of the house. The other things, those take-back days, we see a lot of waste and a lot of mail order waste. We've had people return us boxes of things.
Oh, gosh.
We actually had a TRICARE patient that in Gibson County that they wouldn't quit sending the insulin after the spouse had died.
Jason, I want to tell you how much I appreciate our visit today, and I hope that the information that you have shared in a very professional manner that you have shared with us today. But I think the most important thing is know what your body is, know what your pharmacist is, and more than anything else, not to overdose.
Yeah, it's not just about prescription drugs. There's a whole lot of things that go into that.
Thank you so much, Jason. I really appreciate our time today. This has been a very educational program today, and I'm really glad that we've had Jason Kizer from Kizer Pharmacy in Union City on with us here today. That's our program here on 30 Minutes. Paul Tinkle, pre-recorded.
You've been listening to 30 Minutes, a community affairs program on Thunderbolt Radio. You can listen to this broadcast and others anytime by visiting thunderboltradio.com and following the Thunderbolt Radio and Digital YouTube page. Thanks for listening.